Hi, this is Professor Johnson presenting lymphedema management for the treating clinician as part of the cardiopulmonary curriculum. This presentation was put together by Dorothy Pertell, occupational therapist, and Steve Johnson, physical therapist. What we'll begin is discussing the history of lymphatics. What's interesting to note is that early anatomists did not differentiate the circulatory system and the lymph systems. As we look at the lymphatic system in a future presentation here, you'll see that the structure of the lymphatic system is very small, very finite, and so did not have a distinct differentiation, was not large enough to be noted by early anatomists who were really using the non-microscopes, really the power of visualization through their eye to be able to see things. Gasparo Aselli, an Italian physician, is credited with making the first documented differentiation between lymph vessels and veins in 1622. And Gong Tingshong, a Chinese physician, is credited for using various herbs to treat edema in Eastern medicine. His treatment formed the basis, kind of interestingly, the Casely Smiths out of New Zealand. His herbs that he used in historical times are the equivalent of the benzopyrenes that the Casely Smiths are using in modern day in New Zealand to help with edema management. Anatomy of the Body of Man, published in 1653, contained the first illustrations of human lymphatics, and Johann Wessling was given credit in 1624 for having charted the lymphatic system. Emil Vater, PhD, is credited with developing the modern techniques for lymphatic drainage. He did this in the 1930s, but he did not have a medical background. If I'm remembering correctly, he had a PhD, but it was in psychology, philosophy, and so a lot of his ideas received very little attention in his contemporary time period of the 1930s. However, in the 1960s, Johannes Asdonck, a German physician, established the safety and veracity of Vater's techniques and treated over 20,000 patients in his clinic using what's referred to as manual lymph drainage techniques, or MLD techniques. Interestingly, today, a person can become certified in the Vater method of lymphedema management, and there are still Vater courses that people can attend for certification. Foldy, another German physician, performed extensive clinical research and formed the first large clinic to specifically address lymphedema in the 1970s and 1980s. His technique was known as complex decongestive therapy, and that's one of the things that you will note as you start to do any reading or look at any literature associated with edema management, is that there were different schools of edema management that developed different titles for what it is they did as a sort of a trademarking or a uniqueness to their technique. We will talk about some of the commonalities of all these techniques. My personal certification was through a group that's kind of an eclectic group that looks at Vater and Foldy and several other technicians and uses a consistent approach for the treatment of edema management. Ledoux and Kaplan did extensive cadaver research, which was published in the 1970s, regarding lymphatic pathways and tracing of lymphatic pathways. I believe they also were some of the first folks to use an electron microscope. The Casely Smiths in Australia have done similar work, and they use benzopyrenes to help a chemical that helps in the breakdown of the interstitial proteins and results in improvements in edema movement within the tissues. This unique treatment they titled complex physical therapy. So again, I think you're starting to see that different groups creating different titles has led to some confusion. At the end of the day, it is all manual, hands-on treatment of tissue in order to reduce edema. A brief anatomy and physiology lesson related to lymphedema. Again, this presentation was prepared by Dorothy Bertel and Steve Johnson. So the anatomy of the lymphatic system starts out with the initial lymphatics, which consists of the lymphatic capillaries and the precollectors, which build into the collectors, which eventually build into the lymph trunks, and finally the thoracic duct, which dumps into the vena cava. And along the way, typically in areas of body folds, think elbows, knees, hips, armpits, you have lymph node concentration, which are little bean-shaped filters along the way in the lymphatic system. The initial lymphatic, there we go. Okay. The initial lymphatic anatomy, pictured as a fragile net-like structure that is feather fine with 0.1 to 10 microns in diameter. This fragile net-like structure of the initial lymphatics directly or indirectly covers every part of the human body and is also involved in the organs of the body as well. In terms of the superficial lymphatics, they are located in the superficial dermis layer. It is one layer endothelial cell makes up the initial lymphatics. There are then connector filaments that extend from lymphatic to connective tissue that holds this net-like structure in place. I believe we have a picture here. Again, showing those lymphatic capillaries and how they are kind of interwoven along with the vascular system in the tissue bed. What I'll stop here and discuss just briefly is that the filaments that attach, the monofilaments that attach to the tissues surrounding the lymphatic capillaries, whenever there is movement or a change of position, those monofilaments pull on the lymphatic capillaries, essentially pulling open those single cell endothelial cells, opening them up and allowing them to take in fluid and large molecules. And that is one of the great distinctions between the circulatory system and the lymphatic system, is that the lymphatic system has the ability to absorb large molecules because of the monofilaments that can pull open the capillaries and allow the capillaries to absorb large proteins and cell fragments, etc. Following the lymph capillaries, we have the the pre-collectors. The pre-collectors gradually increase in size and are 1 to 3 layers of endothelial cells. They have one-way bicuspid valves that help prevent backflow, so as fluid is moved along through the system, the fluid goes through the bicuspid valves and is unable to backflow into the tissues. This moves lymph in one direction towards the collectors. The collectors are the main transporting vessels of the lymphatic system. They are large vessels with valves and actually contain smooth muscle. They conduct the lymph proximally toward the surrounding lymph nodes and on its way back to the heart as part of the circulatory system. The 3 layers of cells consist of the intima, the media, and the adventitia. The intima is made up of those flat endothelial cells similar to the pre-collectors and the lymph capillaries. But now we start to see a media, which is that smooth muscle layer of tissue that contracts. And as it contracts, it's squeezing the fluid along the way. And then the adventitial layer of connective tissue. So collectors are composed of lymphangions, which are specific intervalvular units of the lymph collectors. And so the border of one lymphangion forms the valve base of the next one. The valves are every 6 to 20 millimeters in distance, and together they look like a string of pearls. I believe we've got a picture of the lymphangions here, if I'm not mistaken. Okay, it appears we do not. That is something that I will certainly cover in class and do a drawing of. So the lymphangions, if you can picture kind of one unit up against the next, and so when one contracts, it squeezes the fluid into the next lymphangion. The next lymphangion feels that stretch to its smooth muscle. That smooth muscle contracts, and so it kind of starts a chain reaction of fluid being pumped from one lymphangion to the next. The rate of contraction is typically 10 times per minute. These contractions can increase up to 30 times per minute with stimulation such as exercise or increased temperature. We then have the lymph trunk and the thoracic duct. These are the biggest lymph collectors in the body. They have a layering structure similar to that of the lymph collectors. They carry lymph to the terminal pathways in the deep venous system. What you need to keep in mind, though, is that the largest of these is the thoracic duct, and it extends from L2 to T4 and parallels the spine. It starts at the cisterna chyli and flows into the left subclavian at the base of the neck. Even though the thoracic duct is the largest of the lymphatic structures, oftentimes in dissection, this appears to be about the width of a pencil lead, not much larger. And so for a long time, there was significant questions as to what the lymphatic system truly could be doing as part of circulation and edema management with such small structures. What has since been discovered with electron microscope research is that along the pathway of the lymphatic system, there are numerous what they call lymphatic venous anastomoses. And those are essentially connections from the lymphatic system into the circulatory system, which means that fluid that enters the lymphatic system does not have to travel all the way to the thoracic duct and re-enter circulation in the subclavian. And so at the level of the capillary bed, there are connections between the lymphatic system and the circulatory system, and those anastomoses that occur frequently allow for fluid and material to move into the circulatory system and out of the lymphatic system much more readily and rapidly. So what is lymph fluid? Lymph fluid is largely defined as where it is found, and so if fluid that leaves the interstitial space and enters the lymphatic system, it becomes lymph fluid. It is a clear yellowish sticky substance consisting of excess plasma proteins, bacteria, hormone cells, fat cells, tissue waste products, minerals, ions, and water. Of note, lymph fluid is roughly 96% water versus blood plasma, which is roughly 90% water. So lymph fluid itself has a higher water content and is much more fluid than blood plasma. The lymphatic system does play an important role in transporting proteins away from the interstitial space, a large part of which the venous system cannot recover because of what we've already talked about. The circulatory system is a closed system, whereas the lymphatic system has the ability to open and absorb large protein molecules. There can be cases with extreme protein overload in the tissues where the body could suffer massive swelling and even eventually death if left untreated because of the body's inability to absorb those proteins and move them out of the interstitial spaces. So now a word or two about lymph nodes. Lymph nodes come from the Greek word meaning ganglion or little tumor. They are bean-shaped, ranging in size from 2 to 25 millimeters, roughly the size of a pinhead to a large olive. And oftentimes people discover lymph nodes when they have upper respiratory illness or have some sort of viral infection. A common one is mononucleosis, which people get in their teen years typically and develop a hallmark braided lymphatic string along their cervical region. That their lymph nodes become inflamed due to the viral invader that the body is dealing with through its immune system. We have roughly 400 to 700 nodes in the body, with nearly half of those being contained in the abdomen and around the major organs of the digestive system, as well as main groups of nodes being located at the major articulation folds of the body, which I mentioned earlier, thinking elbow, knee, that type of thing, as well as in the cervical region, which I mentioned previously, related to the immune system's function with airways. The lymph nodes function as a filtration and purification station for lymph fluid. So lymph fluid moves through these little filters, and invaders, materials that need to be filtered out of the lymphatic system are caught in these lymph nodes, where the body's immune system can then go in and break down and deal with these. So again, here's a pictorial representation of concentration of lymph nodes, and again, looking at those areas of articular folds are areas of concentration of lymph nodes in the human body. This can become problematic in cases where individuals develop cancer, and that cancer travels into the lymphatic system, which can lead to the spread of that cancer. And so again, in surgical cases, one of the most common that you will see patients for lymphedema is patients who have developed breast cancer, and that breast cancer, they're getting better and better at detecting the involvement of the breast cancer. In the past, just out of safety's sake, if they discovered breast cancer, they would oftentimes strip strings of lymph nodes out of the axillary region as a way of making sure that they got all of the cancer. Because they did not have the skill or the ability at that time to detect whether the cancer was present, it was felt more important to save the patient, even though secondarily these patients then sometimes would develop lymphedema in their upper extremity due to the removal of those lymph nodes. So what does our lymphatic system do? It really serves as a second pathway back to the heart. It parallels the blood system. Lymphatic circulation is a slow rhythm, again, 10 beats per minute is its resting state. So it's low velocity and it's very low pressure process, versus if we think about the blood circulation and the frequency of the heart beating and the fluid moving around the circulatory system, it is a high pressure and high velocity system. Lymph fluid contains components of blood that have filtered out of the capillaries and into the interstitium and now need to be cleaned out of the interstitial space and handled by the body. It was estimated at one point that 90% of the fluid that filters out of the interstitium was reabsorbed by the venous capillaries, and that the other 10% was absorbed by the lymphatics. There's been other research that has reversed this, and it's felt that at some point 80 or 90% of the fluid that filters out of the interstitium starts at some point in the lymphatic system, but then quickly jumps via those anastomoses into the circulatory system. I think that the reality is probably somewhere in between, that more than 10% of our fluid is handled by the lymphatic system for some brief period of time, but would be surprised if it was 80 or 90%. Lymphatics absorb the majority of large molecules such as plasma proteins, fat cells, hormones, molecules, and cellular waste products that have no other way of getting back into the body's circulatory system to be filtered by the kidneys and the liver and cleaned out of the system. And so instead, they're picked up by the lymphatic system and then moved into the circulatory system through those anastomoses, as we discussed. And if lymphatics cannot carry enough protein away from an area of tissue, the result is edema. So again, here's a picture of a real-life patient that I have treated in the past with some very obvious signs of edema overload, fluid overload in their lower extremities. And by the end of these lectures, you guys will be able to identify and diagnose some of the things going on with this person's tissue as a result of the fluid overload, and come to some conclusions as to the type of fluid overload that this person is suffering from. Okay. That concludes lecture number 1 related to edema management. I thought I would give you guys a small laugh to see how it is I spend my spare time with our dog Ripley and our former cat George, who has since passed away. But this is how I spend winter afternoons, staying warm with those two serving as warming rocks for me. So, okay. Thank you. I will post this lecture along with 2 subsequent lectures related to edema management.